So I just want to start by just shouting out nationally. We've seen incredible investments across the United States and in other countries investing in data and data sciences within medical schools and within healthcare. Stanford University created a department of data science in their School of Medicine. And I think that was very, very forward thinking about really the challenges that we are all facing with the massive amounts of data that we're collecting and the opportunity to improve the health of the population and also improve how we treat patients within healthcare settings using data and the computer systems that support that. Harvard Medical School created their first department. This is probably, 8 or 10 years ago now. The first department in their medical school in something like 100 years, a department of biomedical informatics. And again, this is really understanding the importance of data, informatics, and the advanced methodologies that come from data that can then support that. And this is really touching a huge amount of areas. And then UW is creating an Institute for Medical Data Science. You'll probably hear more about it. You'll hear more about it in my talk, and then you'll probably hear that theme throughout that. And this is really the kickoff for that institute. So we're really excited to be here, and we're hoping that we'll be able to do this every year. And again, these investments aren't limited just to administrative units. Universities are building buildings around data and data science, and these buildings are again, really thinking about how we are going to, as an academic community, going to support the massive changes that we're seeing that are being brought about by data. The University of Washington has a huge number of strengths. I don't even need to tell most of you there. College of Engineering, the Allen School, the Information School, the Department of Biomedical Informatics, the School of Public Health, the School of Medicine. UW Medicine is a healthcare provider, and I think all of our opportunities and all of our units can come together, and I hope really do cool things with all of the stuff that we're doing that you're going to hear about over the next day and a half. The School of Medicine itself is also a platform for enabling a learning health system, the idea that we can leverage data and technology to improve healthcare and throughout the 30-plus departments that are in the School of Medicine. I think it really gives us a platform to enable these sorts of collaborations across schools and the colleges at the University of Washington. So again, really, really, really excited about that. And above all of that, for data, machine learning is now commonly used in healthcare and in digital health. You're going to hear an enormous amount about that over the next day and a half. And what I like to say is relational databases are really good at telling us how many patients registered, like say in an emergency room yesterday, but are not good at telling us how many will check in tomorrow. And our goal is to be able to develop those new tools to tell us how many people are going to check into our emergency room tomorrow, or anything that's forward-thinking to help improve that. Again, here at the UW, in my role as Chief Research Information Officer, I have seen a very large number of projects that are leveraging every possible type of data that you could imagine that could describe a patient or a member of the population and their health. We're seeing clinical and electronic health record data being used for research. We're seeing genomics and genetics. We're seeing what I call multi-omics, these high throughput technologies that can basically look at molecular data sets from biological specimens, radiology images, public health data, patient-reported outcome data, where we're starting to think about asking patients, did your healthcare improve based on the last diagnosis you got? And can we use that to improve healthcare? Environmental determinants of health, digital health, such as an Apple Watch that I've got here that tracks my sleep every night, behavioral data, social media data, et cetera. I think you could probably think of a large number of other types of data that would be here that could be here that we could explore as part of research that we could do to hopefully improve health and healthcare. So, today, there's something like 5,000 to 8,000 diagnosable diseases. Most of those are rare. That is, they occur in less than one out of every, say, 1,000 or 2,000 individuals. 25 to 30 million Americans likely have a rare condition, and this is far more than any provider can individually diagnose, and we think computers can help do that. Most of those rare diseases have a genetic component. Again, thinking about advanced data and how we might be able to diagnose them, and it's a significant challenge to try to identify from that data what are the actual markers or the things that we could use as diagnostics to help us identify or understand what those conditions are. I'm a geneticist by training. I'm going to tell you over the next 5 minutes or so a little bit of a story from my own research that I hope will kind of help seed the sorts of things that we're talking about, how we can go from generating a large amount of data and turning that into direct clinical care at the point of care using genetics. 20 years ago, in 2001, the original draft of the human genome, this multi-billion position length sequence of A, T, Gs, and Cs of DNA was published and created a platform by which we could then try to look for markers or diagnostics that were genetic. And this is really mirrors a lot of activity that we're doing now today in academic medical centers where we're generating massive amounts of data that we're trying to then turn into something that we can translate to improve patient care. And the genome is just one of many of them. And we then saw a lot of activity of investigators, of researchers, then leveraging that data and trying to build new methodology that can do things that would improve care. So if we had a genome, we have a genome, and one of the first things that people have done, geneticists have done this for many years, is that we want to find regions of that human genome that are associated with a disease, for example. And so the way that we did that was through statistical association. We created a population of people that would have a disease. Those are cases. We create a bunch of population of people that are participating in a study that don't have a disease. Those are controls. And we look for genetic elements that seem to be different in the individuals that have the disease versus the individuals that don't have the disease. This is basic statistical association. If you've ever done 23andMe and they predict whether you can roll your tongue or not, they're doing the same thing from their population and the genetic material that you've provided them that they've then done to do whatever it is that they're doing. So what we're doing is thinking about genetic risk on an individual patient for a disease. We're kind of looking now at one of those types of data that I just mentioned based on the platform of all this data that we've generated when we sequenced the human genome and did this. And not surprisingly, there's a lot of interest in being able to take a patient and in, like, say, a laboratory testing setting or even at the point of care to be able to identify whether that patient has genetic elements that make them at risk for a disease, and can we use or predict things from that. And so data scientists, machine learning folks, like myself, have developed computer algorithms to identify those variants at the point of care or within a laboratory testing scenario to try to support a provider or a provider in making clinical decisions, like, say, a medical geneticist. And the way that these work are very straightforward. We take a database of genetic elements across the genome that we know that don't cause disease. We take a database of genetic elements across the human genome that do cause disease, and then we ask a very simple question is, can we identify data-based attributes that will predict whether a variant that we see in a patient is associated with the benign database or the disease database, and if it's associated with the disease database, we might think that or hypothesize that that variant is in fact giving a risk to that individual. I'm going to skip the ROC curve plot. So we've developed methods. In fact, there's libraries of methods that have been published, and these methods now are actually used in practice that help support. The method that we've developed is called MutPred2. I'm not going to talk in detail about it, but basically what we did was we took all that data, we built a method like I showed on the previous slide, we published that method, and then made that method available for providers to use. And then we compared our method to a bunch of other methods using an ROC curve like you see here that we put into our paper. All right, I am going somewhere with this. So and now we have actually gone back and said, how well do these methods work clinically? And just recently, in a tour de force publication that I think is going to get a lot of notice, my former postdoc, who's now a professor at Mount Sinai, Vikas Pajever, worked with the ClinGen consortium to show that these in silico methods, in fact, can give a very high level of evidence when trying to identify patients that may have a genetic disease in practice in the clinic. But this is a pretty standard practice. A lot of data scientists here at the University of Washington are doing very similar things. They've got a large amount of data. They've got a bunch of patients that may have a problem or not have a problem, and they then use that data to build some sort of machine learning algorithm and that they can then use to improve, like, say, patient care or something like that, whatever it is the problem that they're trying to solve. And then they publish a paper that puts a plot like the one that we did in our paper there. And I want to emphasize that we're missing a lot when we do this kind of standard practice. The traditional model of writing a paper, developing an application, writing a paper, publishing it, and then reading those papers after the fact and doing something with them clinically isn't enough. And I would argue that we don't know anything about what happens when we start taking AI and applying it into a clinical workflow. We don't know whether patients or providers are actually using that. We don't know whether it satisfies them. We don't know whether it distracts them. We don't know if patients benefit from it. We don't know whether it's actually showing the value that we expected when that was proposed clinically. And we don't know whether it brings value to the health system. We've known for a long time that data can help support providers. So, for example, clinical decision support tools using computer-based methods have been known for a long time. And the hypothesis is that a large number of medical errors occur, and that informatics or database tools, data-driven tools can reduce medical errors in clinical settings by basically alerting providers that there may be best practices or things that they can do that will help that. And then and the problem is that that's a balance with trying to not over-alert providers and basically tell them a lot of things that they don't want to see. And an example of that, a 2014 study found that patients in ICU settings, critical care settings, were basically triggering up to 187 audible alarms in a bed per day. And so the idea is that, well, machine learning might be able to improve how we treat patients in these settings by basically identifying patients that may be deteriorating to providers early, but if there's too many alarms or too many alerts, providers will start listening to them and we'll get a concept of what we call alert fatigue. Again, it's an opportunity. At UW-Medicine, if we wanted to bring, like, say, artificial intelligence to the point of care or to the business of healthcare, that's a hard problem. We have to have high-quality data. We have to have data governance that supports that data. We have to be able to give investigators or data scientists access to that data so they can build new methods. We have to have HIPAA compliance within the computing systems that are building and deploying those methods. We need to have an EHR. That EHR has to be modifiable so that we can integrate what we do. We have to have technical interfaces between our data, the methods, the EHR, and anything else that we need to be able to enable to deploy any sort of method into healthcare. We need to have regulatory compliance. We have to be able to show that the methods that we're deploying are not replacing doctors, and if they are, they have to be FDA approved, likely. You'll hear more about that today. We need also clinical, robust governance for, how we do things clinically and how we do things in, quality improvement or continuous or research settings. And we have to have governance for the machine learning algorithms or any sort of AI that we would implement into, like, say, UW-Medicine, and the resources to actually do that implementation. And then we have to be able to continuously improve it over time. This is the problem that every healthcare organization in the United States is going to have to face if they want to implement AI into practice. They need to think about a lot of these different, these activities, and every single one of these steps is hard. And from that, here at the University of Washington as an academic medical center and as a university, we really want to be able to build those new collaborations to do new things, to innovate on these platforms that I just described, and be able to I think one of the things that I would love to talk about for example, in the breakouts tomorrow is that I'd love to talk about how we can run pragmatic research, like we can implement AI into care and or data-driven methods and study them in care in a way that's both compliant, safe, as part of clinical research. So we're building an institute for medical data science and really that's why we're here. The overarching goal of this institute is to implement AI and machine learning into healthcare and to study it. And as opposed to generate, we will, as part of this, we will generate data. As part of this, we'll do other things. But I think really the goal is to really understand those effects and move beyond publishing papers with an ROC curve to actually show what the effects are of, like, say, for example, clinical decision support that is machine learning or data-driven. We've developed specific aims. I'm not going to go into too much detail about this, but our goals are really to develop open and fair AI ready data sets from, like, say, UW Medicine or other collaborating healthcare organizations, to develop new methods, to implement AI and data science methods into care, and then to study the downstream effects of those methods that we've implemented into care, and to investigate new types of data that may improve health or outcomes, and to improve patient health and provider satisfaction regionally. We've identified a number of programmatic areas. All the talks that you're going to hear about over the next 2 days fall into them. The idea of care delivery transformation directly using advanced data-driven methods, new advanced diagnostics, the business and healthcare operations of the societal impacts of health AI, and what I call technology innovations for discovery. That is basically identifying and doing research like we always do to identify new markers or new methodology to do that. And then obviously as a university we train kind of that next generation of academics. I can't go through this talk without acknowledging the executive team that's been helping support us. All of them will be here at various points during this meeting. Shwedek Patel, Jonathan Liu, Peter Tarzi-Hornock, Dushyant Sahani, Lourdes Ino, and myself. We also have a steering committee that's been helping advise us. They'll be meeting here tomorrow in person. We're really excited about that, and helping guide this overall platform that we're doing. There are lots of opportunities for you as attendees to participate in this beyond this meeting. We have a task force that meets every 2 weeks. Anybody in this meeting is welcome to join these. If you're interested in joining our 1-hour calls, we talk about open opportunities for funding. We talk about projects, and we talk about things that are happening nationally that we're excited about. And we generally have about 50 to 100 attendees that attend those, and they've been really, really great discussions. We also have a seminar that's virtual. If you want to join by Zoom and hear from world leaders in this space, give very traditional academic seminars. These are on Mondays, 2 times a month from 1 to 2:30. There's lots of opportunities to ask questions, and we've been doing this for 3 years now, and they've been just a ton of fun. And I'd like to acknowledge this year's seminar committee that's actually been doing all the work to make sure that these seminars are running without a hitch. All of our seminars end up on YouTube, so you can go back and see the seminars that we've had in the past. And again, I think this is another opportunity that individuals can get engaged. We have a medical data science journal club for trainees. If a student wants to read a paper and present that paper and pick it apart, it's a great opportunity to criticize and to learn things about what we're doing. This has been run by Aaron Lee for the past several years, and also is a great opportunity for trainees in your group to learn and hear about kind of the science of medical data science. All right, so I've got just a couple of minutes left. We do have pilot projects. We have a funding we had a funding RFA. We'll have them every year, so we'll have one in about 6 months. Really, the goal is to bring together computational and clinical investigators to do something that fits our aims. We had our first deadline about a month ago. I was hoping that we would be able to announce the winners who we were funding at this meeting. We're not going to because we're behind, but we will eventually. All right, just to finalize up in the last 2 minutes, and then I'm going to cut myself off and hand it off to Ali Shojai. EHRs, vendors, are now putting machine learning into their software. This is not an academic thing anymore. we're getting machine learning tools that are being handed to us, and health systems that are providing healthcare across the country are turning them on, sometimes with very little thought, in my view. And and I think there's a lot of challenges with that I think we really need to take into consideration. So for example, one of the models that the Epic EHR provides is patient no-shows. Nationally, about 20% of patients miss their clinic appointments and don't show up. And from the business of healthcare, when you miss appointments, that's a problem. And so we would like to intervene in some way to help patients actually get to their clinic appointments and to and to be there. So we could send them a text message. In fact, all of us now probably get text messages when we go to the dentist or the doctor beforehand, telling us that we're going to be there and ask us to actually confirm that. For serious patients, we could even send a taxi cab and get them to pick them up. We could also intervene by maybe perhaps overbooking clinics. Like if we know that a large number of patients are likely to miss at a certain period of time or in a certain clinic, we could overbook that clinic to make sure that they're busy throughout that time. And I think there's a real worry if we were to take that data and build a model, that those models might harm populations that we really, really care about based on, for example, gender or race or age or history in the health system. And I think that I think that an institute like the one that we're describing here can help kind of give us insight into how these methods actually perform, and are they actually equitable and fair in the way that we expected them to. All right. UW Medicine has 30 years of clinical data that we've been collecting from all of our clinical activities across our 3 or 4 hospitals, our the neighborhood clinics that you see, the primary care clinics that you see around the city of Seattle. There's a little less than 100 of them. Our 400 specialty outpatient clinics, our trauma center, our cancer center, the airplanes and helicopters that fly patients around. All of that is accumulating data on millions of patients. We now have more than 5 million unique lives in our database, and basically all activity is there and is, I think, largely underutilized for what we could do with that. We've developed a platform for accessing that data called Leaf. Nick Dobbins, who's here, he's going to talk a little bit later today. This is self-service, and investigators at the University of Washington, in fact, we have more than 400 of them that have access to it, can access and leverage Leaf data through this web-based interface that is compliant and secure. And we have, as a university, have open sourced it and made it available to other investigators and other universities, and now have more than 30 sites around the world that have implemented this open source software for accessing big data clinical data. I am just about out of time, so I'm going to just very briefly talk about, let me talk about one other thing, and then I'm going to finish it up. I just want to shout out, we're going to hear more from Miliha Yedizigan and Nick, who's both here later today when you hear about NLP and the importance of being able to structure and make social determinants of health available so that we can better treat patients. And I'm sure they'll talk a little bit about the efforts that they've been doing to extract social determinants of health from UW Medicine text and make that available to providers. All right, so with that, I'm out of time, so I'm not going to talk about the rest of the things. But I'm going to thank you for coming. And I'm going to give the take-home message, I think, is, I think really at the University of Washington, we're a leader in the use of data to improve health and healthcare, but we'll only get there through collaborations with engineering, statistics, computer science, informatics, IT, our clinical, both UW Medicine and our clinical partners that we work with, public health, et cetera. And so send an email to Nadej at imds@uw.edu if you'd like to sign up for our mailing list and be a part of the things that we're doing. And with that, I'm going to hand it off to Ali Shojai, who's going to give us his 15-minute overview with me.
Thank you, Sean, and welcome everyone. When we were talking with Sean about how we wanted to structure this introduction and sort of welcome you, I thought about sort of how over the past 2 months or so, because we've been doing a search for new faculty members in Biostat, which is my main home department, I've been gushing about sort of what an amazing place UW is. So I'm going to talk a little bit about data science at the University of Washington and what an environment this place is, and sort of what are some of the resources that are available So that hopefully connects well with what Sean talked about more broadly about medical data science and data science, and will help start the conversation. I don't have a tag on mine somehow, but hopefully those tags that are on the name badges will help us get connected better over the next day and a half, and hopefully launch new collaborations. So, as we all know, I mean, people who are from the University of Washington know this, and sort of many people from across the country know this, that UW is home to many top-ranked departments and programs in medicine, engineering, public health, sciences, nursing, sort of law, business, social work, and everything. And as UW is also a place that sort of collaborations occur very naturally. Somehow these slides are a little bit outdated. I apologize for that. There are a couple of places that I had fixed them, but didn't appear on the website. So I'll mention those fixes. So one of the things that I've been amazed with since I've come to UW is how collaborative of an environment this place is. How much collaboration happens organically, and there's infrastructure to encourage these collaborations throughout the university, both in research and education. I'm going to give you some examples of all these collaborations around data science. And there are also many collaborations with institutions outside of the University of Washington. It's not just the university that is such a really amazing place, it's also the whole city that makes it really fun to collaborate. And Fred Hutch is a great example that sort of many faculty at the University of Washington collaborate closely, either on clinical side through the SCCA or through research with colleagues at Fred Hutch, and there are many joint appointments and affiliations with Fred Hutch. The Allen Institutes, I should say that there are multiple of them in brain science, in cell science, in infectious disease, in AI. They all collaborate closely with faculty at the University of Washington. We have colleagues at the Institute for Systems Biology that collaborate with the faculty and researchers at UW broadly. We have colleagues at Kaiser Permanente Health Research Institute that collaborate with us. And of course, even more locally, we collaborate with researchers at King County Public Health. So all of these are collaborations that don't happen naturally, but somehow in this place in Seattle and at the University of Washington, they happen really, really easily. It's just amazing that sort of all these people come together and collaborate. I'm going to give you, as I said, sort of examples of these collaborations, but I also want to say that thanks in part to the infrastructure that has been set up through ITHS, there's also many collaborations across the broader region, the WAMI region, which consists of 5 states, the 5-state region, that basically researchers collaborate more broadly, and UW serves as a medical hub for the WAMI region. And there are collaborations more broadly in this region as well. So I want to talk a little bit about sort of data science education at the University of Washington. And UW was one of the early universities that adopted data science education. In fact, going back to 2014-15, the first seed was placed through the PhD program in big data and data science. And this, unlike some of the other programs that came out around that time or after that, this was quite unique in the sense that it was a truly collaborative effort. So it was a collaboration among many departments, computer science and engineering, statistics, astronomy, biology, et cetera, and the model was quite interesting. The model of this PhD program was quite interesting. It was set up so that each student who was going to participate in this program and graduate with a distinction that sort of they've done this PhD track would take courses in 4 core areas: data management, machine learning, data visualization, and statistics. And then they would take courses in each one of their respective fields. So they would become experts that know at least the foundations, the basics of data science and machine learning, but also would learn about sort of their own field and become researchers that would be able to integrate foundations of data science into their own disciplines. And this has been a very successful collaborative effort throughout the university. Another example of these educational programs is the Master's in Data Science program, or MSDS, which is a professional master's degree. It's available both part-time and full-time. So about sort of half of the students who participate in this master's program are folks that are working in tech or other industries in and around Seattle, and they participate and take classes at night. All the classes are offered at night. And through these classes that sort of are focused on, have an industry focus. The curriculum, the whole curriculum has an industry focus. There are 8 core courses plus a 2-quarter capstone project that links the students with projects that are important in industry, and through that, students would gain direct experience that then translates into opportunities for them when they take positions later on. And again, sort of as an example, this is a truly interdisciplinary program, and there's 6 departments or schools that are participating in this program. It's applied mathematics, biostatistics in alphabetical order, computer science and engineering, human-centered design and engineering, iSchool, and statistics that have all come together in order to form the foundations of this program. And again, this is not something that you see a lot of other places, that sort of data science is taken in one direction and sort of is missing some of the foundations in other directions. Another example, more recently, the university has adopted a university-wide data science minor that basically allows all undergraduate students across the University of Washington to enroll in a data science minor. And already many departments across the university have subscribed to this data science minor. So students could participate by basically taking a data skills course, a data studies course, an integrative experience in data science, which basically is a project type course, and additional electives, related electives that add up to 25 credits that would then give them a minor in data science. And again, the idea is that it's not just for engineering and statistics and other fields. It's data science is going to be in all disciplines across humanities, across sciences. And the idea of this data science minor is to train the next generation of students who are able to incorporate tools from data science in their respective fields. As another example, there's the data science option, and there are many options. There are many departments that have already are participating in these, 8 and counting by my last sort of check. And there are courses, again, that cover the various foundations of data science, from programming and machine learning to societal impacts of data science and visualization and statistics. So all of these programs are just examples of how UW has approached, broadly speaking, training in data science from an interdisciplinary perspective to cover the foundations of data science that are needed for students to succeed. And there are, of course, data science short courses and professional trainings in addition to formal degree programs. And I'll just give a few examples of these. There are many that I don't know about, so I only give a few examples of these. There's a Neuro Academy Summer Institute in Neuroimaging and Data Science, and there are summer institutes in my home department that on statistics for clinical and epidemiological research, statistical genetics, statistics for big data, and also statistics and modeling in infectious diseases. If you're interested in the last 4 that are on the board, they're opening up for registration soon. All of these happen during the summer, and some of these have been going on for many years. The statistics for big data, we started this using a grant from the NIH BD2K program back in 2014, and that's the youngest of the summer institutes that the Department of Biostatistics offers. So many of these have deep roots. So these are just some examples of the broader educational scene around data science at UW. I also want to talk a little bit about sort of many institutes and research groups at UW that focus on data science related activities. Perhaps most important is the eScience Institute that is sort of home to everyone who's interested in data science at the University of Washington. And so it's an interdisciplinary institute founded initially by a Morris Sloan grant. And the announced aim is to advance data-intensive discovery in all fields. So what they do is really cool that they bring together postdocs and faculty affiliates through eScience fellows. So they bring them together in an environment that they could collaborate with each other and talk with each other. And they have eScience seminars that allow people to learn from each other, and then they have scientific software engineering and software carpentry programs that basically connect researchers from different fields to initiate data science activities. I'll just list some of the others that I know of. Again, I'm sure I'm going to miss many because this is such a great place, and so there are many research institutes. There's the Algorithmic Foundation of Data Science Institute, ADSI. There's Institute for Foundations of Data Science, IFDS. There's the AI Institute for Foundations of Machine Learning. Many of these are multi-university, multi-institution research institutes that bring not only people from UW together, different departments at UW, but also connect them with researchers across the nation. And then there's AI Institute for Dynamic Systems that I'm sure you'll hear more about. There are also programs like Computational Molecular Biology Program, or CMB, and Computational Neuroscience Center that again bring together people with computational expertise together with people with clinical expertise or experimental expertise to advance data science in related fields. Okay, I have one last slide, and that is just to say how the Institute for Medical Data Science is going to fit into this puzzle. And to a large part, this idea came about by thinking about sort of what is missing in the broader area of medical data science at the university. And the idea was that following this tradition of interdisciplinary collaboration, the Institute is planning and hoping to bring researchers and educators from many departments and disciplines together. This is one slide that I mentioned that sort of I had a mistake and I fixed it, but it doesn't show up here. iSchool should also be here. I apologize for not having it on this slide. But sort of it's School of Medicine, School of Engineering, School of Public Health, and iSchool that are all coming together in order to form this Medical Data Science Institute. And the Institute is trying to complement existing UW institutes and centers, as well as basically the broader emphasis on population health at the University of Washington. And the key distinction of this institute is its focus on, as Sean already mentioned, machine learning and AI and data science for medicine and digital health. And the goal is to basically create this environment when again, researchers from different fields could come together, could collaborate with each other, and advance data science within medicine and digital health. So with that, I'm going to stop here. I think I managed to save 1 minute.